Hello and welcome to today's online event from the King's Fund on integrating health and housing. My name's Ethan Williams, I'm a researcher here at the King's Fund, and today I'm joined by Rachel Toms, Vic Rayner and Rachel Byrne. And I'll start by asking you all to introduce yourselves, starting with you, Rachel.
I'm Rachel Toms. I lead on Housing and Health at Public Health England, PHE. And for us, housing is a really important subject because so many people's health is affected by their home or their housing situation. And all of that preventable ill health could be avoided.
And Vic?
So I'm Vic Rayner, I'm the Executive Director of the National Care Forum. The National Care Forum works with the not-for-profit part of the care sector, and I'm really pleased to be here part of this discussion today because I think there's so much to be achieved from the really effective integration of health, housing and care.
And Rachel?
I'm Rachel Byrne, I'm Exec Director of New Models of Care at Home Group. Home Group is a large national provider of housing and care. We are on our own mission to make sure that we integrate for our customers who live with us the offer around housing, health and care, and as part of that, engaging with the NHS and influencing through events such as this is really important to us.
Great. And before we begin, I'll just say a few words about how today's event is going to be structured and about how you in the audience can get involved in the discussion. We've got about an hour. I'm going to start by asking a few opening questions and then we'll move on to questions from the audience. And it's really your questions that are going to drive today's discussion. So please do send them in. Just type them into the box underneath the video. And also please keep them concise so that we can get through as many as possible. So Rachel, to build a sense of the context here, what are some of the ways in which housing can impact people's health?
So firstly, any of us could be affected by our housing situation, but there are some groups of people who are particularly vulnerable to the effects of housing-related ill health, and those are babies and children, older people, people with disabilities, physical and learning disabilities, carers and other people who spend a lot of time at home, or people who are recovering from an illness or an injury. So at PHE we pay particular attention to those groups. And if someone doesn't have a home at all, if they're homeless, then obviously there are disastrous consequences for their health, physical and mental, which is why we see an average life expectancy for homeless women of just 43. Then for people who have got a home, there are three main types of ways in which a problematic housing situation can affect their health. The first way is if they have an unhealthy home. So if the place where they live is too cold or it's damp or there are other hazards at the home. So this could be an elderly gentleman, for example, living on his own. His boiler has broken and he can't afford to repair it. So he's using electric heaters, which are not actually very cost effective, and he's avoiding putting those heaters on. And we see this kind of situation many, many times across the country. So his house is getting colder and colder and it's really affecting his health. The second category is unsuitable homes. So this is where the home isn't meeting the needs of occupants, either because of overcrowding or because the home isn't adapted to meet their needs, such as someone with mobility issues. So an example of this would be a lady with severe arthritis who can't get into the bath anymore, which means that she can't have a bath and she can't actually have a shower. The shower is over the bath, and clearly not being able to wash yourself properly is going to be really bad news for your health. Or it could be a family with, say, 3 children and 2 parents. One of the parents has been a full-time carer for the kids. The other parent has just lost their job, so they can't afford their rent anymore. So they move in with their in-laws, and now there's like 7 people living in a 2-bedroom flat. That's really not good for everyone's health, particularly mental health. And then the third category is unstable homes. So this is people who are living with the risk of eviction or in other types of precarious living circumstances. So thinking back to that family living with their in-laws, if the in-laws decide to downsize or move to a bigger place or move to another town for work or something, and the family realise that there aren't any suitable homes in the area where the children go to school that they can afford with enough bedrooms, then that's extremely stressful for that family and ends up affecting everyone's health. So for each type of housing issue, there's a set of health conditions, physical and mental, associated with it based on the evidence. But kind of in headline terms, those conditions can be respiratory illness, injury, poor diet, risk of falls, and in children we see low birth weight, children missing immunisations, failing to gain weight as babies, lower educational attainment. So there can be really big long-term consequences for the next generation.
Vic, did you want to add to that?
Well, thank you, Rach. I was just going to add that I think there's something also about there's a group of people who now, particularly older people, who are remaining in their own homes, who are quite capital rich but very cash poor, and I think that has a real knock-on impact. Some of the things that you talked about in the context of maybe not having sufficient funds to heat their home and causing sort of ill health through the built environment, but also not being able to access care and support at a time when they need it, so not being able to access services that might prevent further decline in health and further ill health. And I think we've kind of created a sort of scenario where the home is king in a sense, and what we now have is a society where there are lots of people with their own homes and being encouraged to remain within their own home for as long as possible, and that's building this whole the whole escalation of our understanding of the ill consequences of loneliness and ill health in that way. And I think that's another element of how homes can positively contribute to people's health, but also remaining and being sometimes feeling quite trapped within your own home can exacerbate loneliness.
Yeah.
I think as well there's just the sheer lack of enough housing in the UK. So work that the National Housing Federation did about 2 years ago, and a lot of us already know this, there's just an annual shortage of around 240 to 340,000 homes a year that we need to just meet the current demand. And that's the tough side of that, is when we see the people sleeping on the street and how we solve rough sleeping and create solutions for that. But it is much wider. It's inappropriate housing and just not enough social and affordable housing. So, not just Home Group, lots of housing associations doing all they can to build and make that accessible, and building to better standards that allow for, I suppose, a reduction in those health inequalities by design. Possibly not fast enough yet, and more to be done around that. And the other bit I'd say actually is certainly for Home Group, but again, lots of other big providers, we do a lot of specialist and supported housing, and the access to that probably is still quite contained within local authority commissioning and referrals, but that could be opened wider, and definitely is one of the root achievements of supported housing is meeting some of those health inequalities, because it's the care staff and the support staff that work in those that see that and help.
And so, Vic, what are the kinds of things that people might mean when they talk about integrating housing and health?
Well, I think, I suppose I think of it at a number of different levels. So I think if we're going to look at the kind of that integration of health, housing and care, I think you've got to start at the commissioning level, as Rachel's just indicated. So we're increasingly seeing local authority commissioning patterns change to incorporate, particularly from local authorities, a shift sometimes away from traditional care provision into more of a kind of housing offer in relation to older people's housing, but also working age adults. So the growth of models of housing such as extra care provision and more specialist and supported housing, which is to be encouraged, I think, at one level, because there's not enough of it now. We know that the statistics, particularly around older people's housing, is that the amount of available older people's housing probably addresses about 4% of the population. So we're a long way away from having achieved a full-scale engagement with that. But I think it shouldn't be to the detriment of other models, because actually, we are in a position where the needs of communities as a whole are varying significantly, and that's going to grow as we move forward. We know we've got a very significant demographic shift going on within communities, but we also know that there are other parts of the community that are emerging, larger black and minority ethnic communities and older people's communities, larger LGBT communities. There's a whole set of changes going wrong. And so I guess in context of the integration of health, housing and care, that commissioning has to happen at a local level, really, really reflective of the local community and its needs now, but really importantly from a housing perspective, particularly that it's looking 10, 15 years in the future to what that set of communities is going to need. I think there's some other elements that are really pertinent around this, and one of those is about the workforce. Certainly, speaking from the care perspective, there are massive shortfalls in the workforce that's available for care. So on any given day, we talk about having 110,000 vacancies within the care sector. Health is equally struggling in relation to vacancies in relation to key roles such as nurses and GPs and others. And I think in the housing context, in the supported housing context, depending on what local employment is like, there are probably similar struggles. So the integration of health, housing and care provides some real opportunities around that in terms of how the workforce is recruited, what the local narrative is about how services work together and join together, opportunities for different career pathways between services. So those are real opportunities as well. And I think the final strand is about people. When you talk to anybody who is, in receipt of perhaps living within some supported housing setting, receiving some home care or domiciliary care coming into that space and is tied into a variety of different health services, they can't understand at all how these services don't connect and talk to each other. It makes absolutely no sense. And I think as we move forward into an environment where people's expectations about how seamless services ought to be and how integrated services ought to be get bigger, and rightly so, we've got to be able to answer those questions about why we can't connect. Why is it that if I've gone into hospital and then returned into a care home, that care home can't access my medical notes and the medication that I've been prescribed in hospital? Why? So we've got a really big piece around data transfer, data interchange that I'm sure we'll talk about more as we go on during this session. But that, for me, is really key, that we get that pathway of data interchange, so that as an individual, people really feel that they're getting the best care they need, whichever part of that system they're involved in, because the system's talking to each other.
And building on that, Rachel, could you tell us a bit about the work that you've been doing in this area, and particularly some of the lessons that have come out of that?
Yes, yeah, I'd love to. So we, as an organisation, decided about 2.5 years ago that because we have such a large supported housing portfolio, where could we have the greatest impact and focus that more strategically? So we took a decision to work across learning disabilities, mental health and older people. But we wanted to make sure that the offer was integrated and not just keep responding to commissioning through adult social care, good as that is, but we weren't necessarily engaging with health. So we have moved our model to one that we call a new model that has both clinical and a more traditional care and support offer combined. We invested in clinicians, so when we respond to a tender to run a service, it will have a mix of care and support colleagues and clinical input. And then we have worked tirelessly over the last 2 years to talk to individual NHS trusts and with NHS England, with the support of Confed and King's Fund, to get that message across that housing is a really strong offer to health to help solve some of the issues that they are facing. So what I thought I'd quickly do is just give you some of the top findings and learnings we've had through that experience. So the first, and I'll use a little bit of data for this that came up from the NHS Confederation conference a couple of weeks ago. We did a mini survey on what their view was about the housing world and the housing offer. The top thing was that trusts and CEOs and people who answered the survey said, we just don't know what the housing offer is. We don't know how to access it. We think we need it, but either you need to tell us or someone needs to tell us what it is overall. And it is, at the moment, I feel provider-led, that message to trusts from housing providers, and it needs to be wider than that. And the second thing was, and this is in relation obviously to our new models and the supported housing portfolio, is their confidence or lack of confidence about whether or not we can manage complex individuals. So this particularly comes out around learning disabilities and mental health. So rightly so, nurses discharging people into a housing solution want to know that their overall care or their progress with their diagnosis and rehabilitation is going to be managed well. Now, we've done that through investing in clinical infrastructure and clinicians in our services, but that's a cost to do that. And I just think there's still a way to go to prove to health that we can do that and it's safe. The sort of third area is actually back to some of the data issues, but in a slightly different slant on it, is we have used NHS Trust's data to play back to them and then show them what the housing solution is. So recently, and had a lot of coverage, is our mental health step down that we did in partnership with Greater Manchester Mental Health Trust. And we used their high figure of costs for out of area placements and showed them that there could be a housing option that would be incredibly cheaper than what they were paying either in the private sector or in their own acute beds. And the way that relates to housing is it was actually about taking people from acute wards, about 80% of whom were homeless. And whilst they still had their mental health issue and diagnosis, really, they just didn't have anywhere to be discharged to. So it's so obvious that if you use housing professionals who know how to access housing, then it's going to work better. So in the last 7 months, 24 people have been through that service. About 60% of them we've rehoused either into their own home or long-term supported housing, and the saving to the trust has been dramatic. And we are just about to have our 12-month evaluation. And that data, so what I've learned, and sorry if this sounds naive, is that the NHS trusts their own data, but they don't trust anybody else's, and they don't trust you playing back to them how you've looked at their data and interpreted it. So having the NHS work with you in housing and have confidence in what you're delivering is to me one of the biggest learnings, but it takes investment. And the last bit I'd say around that is also leadership and trust. For housing, we need to be confident about our housing offer and demonstrate strong leadership that actually NHS and health, you will benefit from this if you then trust us back. And if my colleague from Greater Manchester Mental Health Trust was here, she said very strongly at the evaluation review that we did that it's about seeing the same person as well. So being able to build a relationship with ex-housing provider and knowing that you'll stay the course and work through the services. So I think we're doing well. It's the tip of the iceberg about what actually could be delivered if we integrated all three.
So we're getting lots of questions in now about good practice and people wanting to hear examples of where things are working well. So Vic, perhaps I could start with you. Where have you seen models and approaches that are succeeding and other areas can perhaps learn from?
Well, I was going to also pick up on Rachel's point, but maybe the two things combined together, because I think the issue that you're raising about trust and leadership are absolutely critical, because I think where examples of where it's working well, that trust and leadership has been worked on and embedded. And one of the challenges about the kind of data sharing element of things is that there was quite a lot of work done 3 or 4 years ago around data sharing protocols between local authorities and health trusts. But I suspect housing providers and certainly care providers were left out of many of those discussions. So what that means is now that we are, really trying to go round that loop again, we've got to start all over again in terms of bringing in that trust. So examples of where the integration of health, housing and care does work well. So we've got a number of our members within the National Care Forum who have been really pioneering a type of kind of village model of care and housing and health all being connected up together. So up in the northwest there's a not-for-profit organisation called Belong, who deliver, now have I think 8 or 9, possibly nearly 9 villages, where on a co-located site they will have care home provision with some nursing on site as well. They'll have extra care provision available as well, so they've got some separate tenancies and people can, and then they'll also have domiciliary care provision on site. But there they've been also in some of those able to kind of co-locate GP surgeries and other kind of allied health professionals being able to utilise those services. So I think one of the things that housing and care organisations are very good and helpful around is that they can unlock, sometimes they can unlock capital, which is helpful for local authorities in terms of kind of more general housing need build, but they can also provide space and have good kind of connections with health professionals who can then utilise that for wider work. So I think there's some good practice examples. I think there's an awful lot more even in those localities, particularly around this kind of evidencing and sharing of data and being able to build a picture where it's not, we need to get to a place where it's not reliant on the same individuals being in place, because this is a story I hear over and over again about a relationship being built between a trust and care provider or trust and a housing provider, and then personnel change, and suddenly we're right back to faxing information or, whatever it might be, because the trust has gone, and so we need to be built on much sturdier foundations than getting on with somebody and trusting them. We need to build it onto a much more steady footing.
Rachel, I wonder if you wanted to add to those examples of good practice.
Yeah, that's right. So we know that about 1 in 5 homes around the country are of a non-decent standard in terms of the state of repair and the condition of the heating system and insulation and so on. In many parts of the country, organisations have come together to try and tackle this in order to improve residents' health and to enable people to remain independent at home by setting up a kind of single point of contact housing and health referral service. And they have different names and different scopes in different parts of the country according to what the partners have established. But in Middlesbrough and in Derby and in Cornwall and the Scilly Isles, they've all set up really strong programmes to help people stay warm at home, get things fixed, sort out heating systems. They often provide a handy person service to fix those bits and pieces that might be presenting a health hazard in the kitchen or in the bathroom. And by providing a really coordinated service, a lot of people have benefited.
I pick one that I think is emerging best practice because it's not completely fixed yet, but I think the work that housing providers and care providers are starting to do around the Transforming Care programme. So providing a strong offer and reason why somebody should come out of hospital, particularly around learning disabilities, and that the housing and care offer can deliver. And I also raise that because we are starting to see that being jointly commissioned, and that is always a great start to that integration. So a lot of the Transforming Care individuals who are thankfully coming out of hospital are commissioned both across adult social care and health. And the solutions, they require investment and sometimes 2, 3 to 1 support, but the housing is absolutely critical, and I think the stalling of that programme to enable people to come out of hospital was purely a housing blocker. And I think so the work we're doing has been actually about purchasing properties and bespoking them to suit the individual and going right down to the real granular detail about what that individual needs. And we're just at the point now, which I'm very happy about, that we will actually start building for that group of individuals as well. And you only have to look at how poor the mortality rates are for people with learning disability. Some of that is because of this going between home and hospital. So I think housing, stepping into that is good practice.
Go ahead, Vic.
Well, I suppose I think a lot of it is about having a shared vision, isn't it? I think part of the success of any of these is about having a shared vision between those parties. So another great example is in the West Midlands, an organisation called Accord, who have led a kind of integrated partnership between health, housing and care. Accord are a housing provider and a care provider, and have been able to develop one of the first specialist extra care provision for people living with dementia. And you know that absolutely is part of a priority for health commissioners, for local authority, ensuring that people living with dementia have got the best possible outcome for themselves, and you know support for carers and others around. So there's a kind of real shared ambition there about creating an environment that enables people to thrive for as long as they're able to and live as independently as they're able to do that. And so I think you know that is part of that a part of that success story. I think the challenge is that we have created you know essentially quite a kind of competitive commissioning environment. And we've got lots of ambitions around integration in the context of pooled budgets and other things, but we've created a bit of a scenario where we've got both a competition between providers, but also essentially or potentially commissioning a competition between those commissioners as well, those health and local authority commissioners. And I think what we need to be looking at is these solutions having a really strong focus on what works for the locality as a whole, and moving us forward with some of those discussions around pooled budgets so we can get more of those successful schemes.
Rachel, I wondered if you had something to add to that too.
Yeah, so we've touched on new build and the need to deliver more homes to meet demand. And people may be familiar with the NHS's Healthy New Towns programme, which has been exploring over the last 3 years how to hardwire health into new housing developments in terms of the individual dwellings, but also the streets and the public spaces, and the community facilities and shops and services and schools, and the transport and neighbourhood design, plus looking at integrating healthcare services and supporting community life and building social connections in new housing estates and new developments, because there are some massive ones going on across the country. So there have been 10 demonstrator sites where a lot of new housing was being built or being planned anyway, that joined the Healthy New Towns programme, and they've all been exploring different ways to meet local health needs and future health needs in the design of the new housing. And over the next couple of months, there's going to be a publication setting out all the lessons that have been learned from that programme that will be launched. But already online, there's a leaflet setting out the 10 key principles of building healthier new towns and urban extensions. So people can find that by looking at NHS Healthy New Towns.
I'll just add something on the workforce actually when Vic was talking about that. And again, it's quite obvious, but I think it gets forgotten, is when the workforce is shared. So in lots of the schemes and examples we're talking about, we've got clinicians and housing and care staff working together. And that still is quite a new thing, but the impact for Accord definitely is around that. Some of our individual schemes where we've worked with the trust and then they've allowed a clinician to work with us for so many hours a week, or it's just tied into what the trust is doing. More of that would be good.
And how do you support teams working together? What are some of the challenges and opportunities there?
I think so. Where that's in some of our services, I think first of all it's actually about allowing them some time to understand each other's perspective. And it's interesting, we employ, I think to date now, about 22 clinicians in our services, and when you put them together in a room with our more traditional care and support and housing staff, it does create a tension. It's a good tension, but that's the opportunity for them to learn the perspectives of the others. So I don't think any of these things just happen easily. We have to invest in the time to understand perspective and respect skills. And also, I think the other challenge is respecting the expert. So, and there are experts in care, housing and health. not one of the three trumps the other two.
Go
Yeah,
ahead.
no, I was just going to say. I mean, I think from the workforce is absolutely critical to that, and there are lots and lots of learning opportunities. And I think if we look, 5 to 10 years ahead, particularly around some of the changes that health, housing, and care are going to experience in relation to technology, I think there are huge opportunities there for some learning too. Because I think all of the focus on kind of hardwiring the homes for the future, in a sense, is reliant on a certain level of technology being part of people's lives going forward. And I think, if I look at something like the Topple review that came out in relation to healthcare professionals and their need to develop skills around technology, I mean, I read that and there's nothing different in terms of those new skill requirements in terms of the sort of the day-to-day working than there would be in care or there would be in housing. And I think we've got a really unique opportunity, in a sense, to say, why don't we at a locality level bring those staff together to learn something that they all need to know together, but really importantly to learn about each other, because it does seem, a bit like that whole kind of sense of amazement from somebody that data can't be shared. I think there would be an equal amazement that health practitioners didn't understand what social care providers did, and social care providers don't understand what housing do. We've got a bit of work to do to get our own understanding in order. And I think you talked about sort of what workforce integration might look like in practice, or having different people from different disciplines within settings. I mean, there's certainly things that we can, as quickly as possible, stop happening now. I mean, one of our members has a set of, as part of a reablement programme, has a set of clinicians based within the home. It's not they're not being employed directly by the care provider, but they're located within the home. But because they're off-site, even though they're still employees of the trust won't allow them to access the records of the people they're delivering reablement to who've just come out of hospital. And you just think, we've got to get some of that right really, really quickly, because we're missing so many huge opportunities.
And you touched on the theme of technology there, and we've had a question in from Kimberly Rigg, who asks what you see the role is of technology and data collection. And Rachel, I wonder if we could touch on you first for that.
She said, raising her eyebrows.
Are you seeing technology getting involved in your practice?
So I suppose I'm more hesitant about the data piece. Okay. So technology, one of the things we're doing at the moment, so we have somewhere called a Gateshead Innovation Village where we're testing out modular construction. So we've built 42 homes and they're all different modular forms, but one of those homes is purely for new models of care. So that is testing out lots of different technology that will support people living in their own homes, as well as whether modular will work for some of the work we want to do around mental health and LD. So lots of stuff around being able to manage the property yourself, being able to restrict certain areas so different people can come in, different pieces of tech that it's supported by Northumbria University. So they are I think they start in August. So we'll have researchers living there testing out the tech, and then if that works, we'll use it in our schemes. But we are still learning around that. We don't have huge pieces of good practice around how we're using assistive tech or technology more widely in our schemes yet. Our ambition is there to do it, but I suppose that's why we've partnered with the university to help us get there.
And Vic, do you have anything to add to that?
Yes, yeah, definitely. I think this, particularly to talk from the care perspective, we have, as a sector, been largely untouched by technology for many, many years in a way that, almost every other part of society has been. So I think there's great potential and great possibilities, and we're starting to see that escalate relatively quickly. So even very sort of simple, well, not simple, but very fundamental things like electronic care planning, for example, and electronic medication management are starting to take hold within organisations, which from the point of view of how we are collecting data on people is enormously important. At the moment, in a paper-based system, you might have a care plan for an individual that looks like that, records possibly up to 150, 200 or so interventions a day and notes about people a day, and at the end of the day gets popped in a filing cabinet and of course referred back to as needed, but doesn't drive forward improvement. So the excitement of something like electronic care planning and it is that what you then get to see is what really works well, and that can drive forward and improve service delivery and service development. So where we've got members who are really interested in looking at that, they're beginning to be able to tell us some really exciting things about that. So, for example, we've got a member, WCS Care, down in Warwickshire, who have set up their own innovation hub. So a great example of good practice in terms of sharing their knowledge, sharing their learning, sharing the things that have gone wrong. They're very, very open about that. But they can now see through their data, they've been on a drive to increase the fluid intake of all of the people who are living with them. And they've been able to track that against then levels of urinary tract infection, against levels of falls, and been able to see significant changes in terms of the outcomes for individuals through being able to have that data. Without it, somebody might notice that those changes have happened, but equally likely they wouldn't have been acknowledged or connected to these elements. So, and I think Rachel's point about working with health organisations and how much they trust or don't trust the data that's provided by others. We've got a long way to go to build up a really robust set of data, and certainly my hope is that as we move forward with that, we will be able to show really clearly who the experts are in each of these contexts, because care will know lots of things about supporting people to live have the most independent life they can at real points of frailty, for example, and in end of life contexts. And housing might have some fantastic data about how to support people to combat isolation and loneliness within the home. Health is going to have fantastic data about how to address medical conditions, and bringing that together, you get a suitable picture of the whole person. At the moment, we've just got really robust health data and not enough of the others.
Yeah, that's the point that I was going to say, that in healthcare, the NHS has a massive amount of data, which is very strongly anonymised and protected, rightly so. In housing, we have less, and at a fine-grained level, kind of by local authority or by ward or by street or by dwelling, we have much less. So in any individual building, you might have very different flats and different occupiers, completely different states of repair that we don't have public data on. Zoopla probably has a lot more than we have in the public sector, but perhaps that's an area that we need to explore, because if we really want to up the ante in terms of our effectiveness to tackle housing-related ill health, then it does kind of rely on having information at a fairly fine-grained level.
And some investment, I think, certainly for care providers. We were talking recently, weren't we, with other care providers, and some haven't got Wi-Fi. So we're a way off, and that will take investment.
Well, and also there isn't, you talked very rightly about the NHS digital kind of data, NHS England and digital data sets, but there isn't that infrastructure that sits there either for housing or for care in that same sort of way. So we need to recognise that these things won't happen without some investment, development of skills, and some standardisation as well. Health has gone through a long process in terms of, working out exactly what a broken finger looks like. We haven't quite, we're still thinking about what, sometimes we distinguish between what we call members of the workforce, and there's lots of things that actually being focused on data are going to force us into some standardisation around that too.
So I'd really like to explore the issue of health inequalities. And Rachel, maybe I'll start with you. We've had a question here from Sarah Clifton Gold from Cotswold District Council, and she says, how can we influence and incentivise planning teams, particularly at district level, to consider health inequalities? So what do you see as the relationship between housing and health inequalities, and how can we help use housing to tackle them?
That's a really great question. And essentially the situation that we have in England at the moment is that people living in the most deprived parts of the country are living in good health, so their healthy life expectancy is 19 years less than people living in the least deprived parts of the country. And that's what we all want, really, healthy lives, not years or decades spent in ill health, possibly with multiple conditions worsening over time. So that's a massive difference between people in the poorest and the richest areas in simple terms. So for local authorities and planning teams, I would suggest that they work with their colleagues in public health, who will be within their local authority, to really look at the data, the population health data on the demographic profile. Some authorities are doing some modelling of the future demographics as certain parts of the country grow. In other places, the population may be shrinking, and to use that information and priorities set out in the JSNA to really inform spatial planning policy and site allocations for housing, and to consider it in looking at planning applications that are submitted.
And kind of touching on that theme of health inequalities as well, a particular area where that's really relevant is with rough sleeping. And we've had a question here from Richard Lewis from Making Every Adult Matter. And he says, how can we improve the conditions of those with our that are rough sleeping with our current health and housing offer? Rachel, can I start with you on that one?
Gosh, there's a lot you could say about this. So first thing I'd say is around the Housing First model. So I'm hoping that more areas will start to promote that and use it. So Manchester have got off to a great start. This is about providing a house first and then bringing all those services that are needed, health and care, particularly around drug misuse and alcohol, and bringing those to the individual once you've put them into accommodation. The problem at the moment is rough sleeping is at extraordinarily high levels, and you can't tackle some of that inequality or health issues on the street. So we need to find a way, one, of increasing the supply of supported housing, but two, I think using the Housing First model, which is certainly a big piece of DevoManc, but is coming in other areas as well. I think as well, I can't help but say this, so in my previous life, I ran a big rough sleeping team in Manchester, and the interesting thing I reflect on now is what a different makeup that was. So the big issue then was very entrenched rough sleepers, older rough sleepers who needed really the benefit of a home. Their health needs were very physical, related to having been on the streets for so long. That is not particularly the makeup now. It's very different, and we're dealing with situations that a lot of us aren't used to around very different drug use and so on. So I think it needs specialist investment on the Housing First model, and also from the health side, which is very different from how it used to be.
And Vic?
Well, I mean, I just think one of the very interesting things about the Housing First model is that it is underpinned by a huge set of data. And
yes,
that has been one of the opportunities in terms of which is quite unusually now in the context of focus around homelessness, of bringing a different model to the table. So we've had a model around hostels and around a pathway of homelessness for many
years,
and Housing First has been able to kind of challenge that narrative because of the data that sat behind it. So I guess it's just there's a kind of learning point in that context about how if we were to secure real change and to convince people about to do things in different ways, that we need to have that piece that sits behind it.
And we're getting lots of questions coming in about prevention, and there's mention about the upcoming Green Paper on prevention. Rachel, I wonder if I could ask you what you see as the potential role of integrating housing and health in supporting this move towards more prevention.
From So from my understanding, one of the main things that's going to be in the paper is around the shift from, I guess, institutional settings and so on to community-based solutions. And as an opportunity for housing, that's massive, because it's probably less about the word housing, it's more about the home. So how do people interact in their communities? What happens in their home? How do we take that opportunity to bring prevention into it, rather than, I guess, what's the current position now? It's more about all very hospital-led, and if there's, if you have something wrong with you, you go there to get it fixed. It's less about how a community can wrap round individuals and deliver prevention. So I'm excited about that. My worry about the paper and what it will hold is that housing will be seen as someone that does aids and adaptations or fixes a roof, rather than the role they play. I think I read earlier a brilliant example about Royal Mail and the fact that, which I've witnessed actually when we went to visit Royal Mail. So a lot of postmen, postwomen, see individuals who are isolated and in poor health, probably more than most of us do. So the role that they are going to be encouraged now to have that wider role to make some form of intervention. It's exactly the same for housing. Housing are often the housing manager or the community worker is the first person people see. So enabling or empowering them to be able to actually make interventions and the right contacts for people would be a great way of preventing some of the health inequality that we see.
Rachel, I wonder if you have anything to add to that.
Yeah, and that contact that those professionals have with a lot of homes, or pretty much every home in the country, in the case of Royal Mail, there's so much potential there. I think it's very easy to underestimate the scale of loneliness and social isolation, and the power of social contact and social connectedness to protect against ill health. It is what keeps us human and keeps us alive in many respects. And in relation to the forthcoming Green Paper, I think that as well as the government setting out its stall for preventing ill health through that Green Paper, I'm really keen for organisations across the country working in housing, health, care, in any aspect of prevention, and the supply chain for ill health or the supply chain for good health, for all of those organisations to respond to the consultation on the Green Paper, so that government can hear all their views and all of their experiences too.
And Vic, is that something that resonates with you?
Yes, I got some alarm bells ringing at the notion that Royal Mail might be our answer to combating loneliness and isolation, and I guess I think that is my, I think there are real concerns if the Green Paper doesn't get to the challenges that are there. We have got a really clear situation where there are lots of people who are extremely isolated and extremely lonely, but we have cut back huge numbers of community services. We've shut libraries. We've taken down bus routes. There are many of the things that we've talked about in the context of this discussion, which are about how people remain independent and part of their communities. Or perhaps we should stop saying independent or interdependent with their communities. And I think I just am wary that we come up with a set of solutions that sort of says that there's a group of people who happen to drop by. I mean, you only get the Royal Mail come to you if somebody sent you a letter. So you have to be connected in some shape or form to be able to access that. And I think that there's always a lot of focus on what else could we do differently? But there are lots of solutions that we already know and have and are tried and tested. And I suppose I think that care is certainly part of that. Housing is part of that narrative. And we've got lots of things that are already there, but we have to be really realistic that unless we have some community infrastructure in place, all of these things will only provide a short-term respite to the issues that people might be facing in the context of their isolation. I think I sound like I'm kind of completely obsessed with technology, and I am a bit obsessed with it actually, because I just think it has got lots and lots of answers. But there's another one of our members called who runs something called wellbeing teams, which people might have come across. It's a new model around home care. It's intended to be a much more sort of autonomous model, much less flatter hierarchy, people work in localised teams. But alongside that model of care, they've also are advocating something called community circles, which is a technology-based approach to circles of care, which are not, again, are not new. But the idea is that when you work with somebody, you identify all the people around them who could be part of their network, and you connect them up digitally, and that could be neighbours, that could be local church, that could be all sorts of family members, that could be the GP, whatever. There could be a whole range of people, and then whenever that home care worker is with the individual providing the home care they need, they can also ask them about what their additional needs are and send that out as a request to the community circle, and that then provides a whole range of other people get to know about what somebody needs and can be part of it and can be engaged with it. And I think we just have to remember what prevention actually means. It is about certainly in the supported housing context and how I think of it, it is about preventing people needing more acute care, and it's about supporting them to be to have the most engaged life that they can. It's not about it's not just about stopping them getting into hospital. Mm-hmm. It's a much bigger picture than that, and I think we've got a lot of the solutions. Of course, there are going to be many more out there, but let's not pretend that we don't know how to do it.
Mm. And a lot of the questions that are coming in also relate to leadership. So, what kinds of leadership are required in local systems to drive forward integration and to make the most of the opportunities that are out there? Rachel, I wonder if I could start with you on that one.
I mean, it all starts from the top, really. I think these ladies might be a bit more closely connected with local leadership. But if you've got someone at the top of the organisation saying, yes, we must bring these agendas together, then you're in such a stronger position than if someone kind of lower down the organisation is trying to kind of chip away. So, yes, it's clearly essential.
Mm.
I mean, I think leadership. I mean, that piece about leadership and integration, I think, is about how is supporting the development of a shared vision. So I think that's a really, that's an important part of that leadership agenda. I think in where we are now currently, in the context of probably some quite significant political changes, some quite significant kind of possibly financial changes going on. What we also need those leaders to be really doing is looking 5 and 10 years ahead and not going for some short-term gains, but going for things that will actually take us towards that much bigger vision of what that I think people are expecting us to come up with a solution about, which is about how we have something that really feels integrated if you're the person experiencing it. Mm.
I think leaders are at all levels. I'm a big fan of leadership rather than talking about management. Mm. So especially if you are pioneering and trying to make new changes, design new models, all of those pieces, you need to lead it, whether that's with a small 8-unit pioneering scheme that needs to be led as well as managed. I think some, and we see it, don't we, where trusts that are really NHS individual trusts who are really active in trying to do either this co-commissioning or redesigning services. They have strong leaders, and their leaders are very visible and talk about where they're going to, and we need more of that. In housing, we have a lot of very strong and strong leaders at the top of our organisations and across our representative bodies, all of whom talk about that integration model. Mm. So we just need to see more of that, I guess.
Mm. So we're coming towards the end of our time. I'd like to finish by asking each of you for one final reflection coming out of today's conversation. And Rachel, maybe we could start with you.
Sure. So great that so many people are getting interested in connecting healthcare and housing. I think that bodes really well. And I think that there's a question for all of us who are interested in the subject and for others in society and in politics in terms of what the right balance is in terms of using public funds to treat ill health and investing public funds in preventing ill health. And housing is one of the ways that we might want to invest.
And Vic?
I think it's got to be about the data. I think we've got to get ourselves to a place quickly where we can both share data, we can understand what that data is telling us, and we can take action as a result of that. I think there's no point in collecting it unless we do something with it, and we have to come to some agreement that, you know, the data that we collect in care is valued as much as the data that Rachel collects in housing and as Rachel collects in health, and that we need to bring that together in a way that helps us drive forward towards that integrated future.
And finally, Rachel.
I think it's about the opportunity that, whether or not we believe it's a crisis in the NHS, but if we say there's an NHS crisis and there's a crisis in social care because we still don't know the long-term settlement, and there's not a crisis but we still need more housing, and we know that, and we know we need to build supported housing, then that to me is the opportunity to integrate them, to get the best out of the three sectors and bring them closer together. That does need strong leadership.
And thanks all for a really interesting discussion. And thanks to everyone for watching and sending in questions. This event will be available to watch on demand over the next few days, so please do share it with anyone who might be interested. For those who want to find out more, we've got an event coming up in September in Manchester on homes and health. But for now, thanks for joining, and we look forward to seeing you at the next online event.